and the Ghana Health Service has confirmed the discovery of 2 new variants of the COVID-19 pandemic in the country. The 2 variants, B1 and B1.525, were discovered by scientists at Yamache Biotech, a cancer research company. The B1 variant was first identified in Morocco and Algeria. It has been linked to increased transmissibility and has been circulating in Ghana since March 2020. The B1.525 was first identified in Nigeria and is said to have appeared in the northern and western regions of Ghana. Right, so that is what we know about these diseases so far, these variants of the diseases so far. Now, it's important for us to keep this in mind because the AstraZeneca vaccine was found to be not so effective against the South Africa variant, which we were told is not so common in the country. Now, the program manager of the extended program on immunization, Dr. Kwame Amponsa-Chiano, who revealed almost 500,000 people have been vaccinated, said government's priority is to speed up vaccination to avoid getting multiple mutations, which could reduce the potency of the vaccines. He spoke on the Super Morning Show.
We know some of the districts are still entering data. They have done the vaccination, except that they did the paper-based entry, and now they are putting it on the electronic platform.
Right.
So we know we should be hovering around almost 500,000.
Okay.
Remember, we had an initial 600,000 doses, which we distributed. We left some buffer just for management's sake. So almost all the 600,000 doses were distributed.
Okay.
The service has been working with WAC. So, of course, you need to monitor the genome or monitor the variant by doing genomic sequencing. And I know the ministry is in talks to do that. I think that only informs whether your vaccines will still be potent or not.
Right. So
far, the only one we know that does not, I wouldn't even say that it's not potent, but it's not as would be expected, is the South African variant. I don't know if you listened to the news last night. The people who actually came out with that, the fact that there were variants maybe peculiar to South Africa, or even worried that South Africa suspended the AstraZeneca in the first place. It was actually out of place because there's still some benefit. So, but essentially what you want to put across is how fast are we able to do our vaccination so that we don't get multiple mutations for which the vaccines will not be potent. I think that's the essence. And it's more of now a global thing than just a local thing. Because if, the whole 6 billion people or 7 billion people in the world are going onto the same 7 or so markets, and there's a lot of pressure. And so it depends on how well you negotiate. And that is why we, from the onset, signed on to the COVAX, because we know that kind of high-level negotiation will give us some vaccines. And we have indication that within the next couple of weeks, up to April ending May, early May, we'll get additional 2 million doses.
We're joined now by a public health expert and adjunct professor at New York University, Nana Kofi Kwache, for more on this. Nana, good to talk to you again. What do we know about these 2 new variants? And I am particularly curious as to how much weight we should place on these findings in the first place.
Well, the discovery of variants in any country is always, or new variants in any country, it's always something that deserves public health attention. In this case, what the researchers at WACBIP and Yamache Biotech are reporting is that we've detected the B1 strain that was originally from North Africa, specifically Algeria and Morocco, and the B1525 strain, which was also originally identified in Nigeria. We know that the B1525 strain, the one identified in Nigeria, generally is associated with some mutations that have the ability to cause the virus to evade existing immunity. So if you had an infection from one of the ancestral strains and you got infected with this strain, it's possible that the existing immunity might not be protective of preventing you from getting infected or preventing you from getting seriously ill. But as far as that applies to what it means for vaccine-acquired immunity, there just isn't enough data for us to know anything in that respect. there's no reason for us also looking at similar mutations in other variants to think that that mutation wouldn't occur in the same way or have the same impact. And the impact, it's similar to the mutation we've seen in the UK strain, where the virus becomes, it generally ends up having a greater ability to evade immunity, which might impact vaccines somewhat. But all the strains we are seeing so far, when it comes to severe illness and death, the vaccines are effective at preventing that. So we don't have any reason to be concerned about that here. With the Algeria-Morocco variant that we're dealing with, there it's associated with increased spread. There's no indication as to immunity evasion or increased severity, just increased rates of spread. And as a result, it means that we have to pay attention to that to make sure to ascertain that our transmission control and infection control measures are actually going to be effective.
So if I'm to understand what you're saying, Nana, you're telling us that concerning the vaccines and how effective they may be against these two new strains, we don't have enough data to know if we need to be worried or not.
Well, specifically to the B1 variant, the one from Algeria and Morocco, there is no reason based on the mutations involved to think that there would be any impact on vaccines. The impact that the higher transmission rate gives you, it affects your herd immunity threshold, because herd immunity is a function of how quickly the virus spreads. So if your average rate of spread goes up, then your herd immunity threshold will go up. But for the B1525 variant, even though it does appear that there is some ability to evade existing immunity from the ancestral strains, there's no reason to think that that might necessarily be the case with the vaccines. And even if it were the case with the vaccines, the critical thing that vaccines do, which is preventing death and severe illness, those are things that all the vaccines so far have been able to do against all the variants so far. So we wouldn't expect to see anything different from that either. So as far as vaccination goes, it might impact our herd immunity threshold if we have a general increase in the rate of spread, but we wouldn't expect to see much of an impact necessarily on the effectiveness of vaccines.
Right. I'm sure that will be very reassuring for persons like myself, I must admit, who have been vaccinated already. I also want to know, it looks like B1 was present in Ghana from March 2020. You are not with WACBIP or the Health Ministry, but how did we miss it? How come we are discovering it in March 2021?
Well, I think that's a question of the structure and resourcing of our genomic surveillance efforts. The folks at WACBIP, Imachi Biotech, those guys are doing an extraordinary job sourcing samples and sequencing them to give us results about what exactly we're looking at in terms of variants spreading in Ghana. The challenge that they're having is that they have limited resources. So a lot of the stuff that they're doing out of grant funding rather than out of necessarily direct budgetary allocations or long-term consistent budgetary allocations. So they can only do a couple of samples at a time. They can only do that sampling ever so often. And then they can only do the sequencing of those samples ever so often as well, because they're limited by resource constraints. What we want ideally is a system where maybe on a bi-weekly basis, we're able to get a sense of what the variants that are spreading are. And so that we're also doing that sequencing with larger numbers of samples so that we have more representative data that gives us a sense of exactly how representative the sequencing results are in terms of proportion of different variants, how representative those are of the real population. So those are it's not a question, at least on the science level, of a lack of effort or a lack of attention. Those guys are doing the work, but they don't have sufficient funds to do this at the scale we need to be doing. And that's something that we really have to look at, because as we roll out a vaccine drive, that data about what variants are spreading is how we can configure and estimate the effectiveness, how we can decide things like the herd immunity threshold, and we need clarity on that. So I really hope that there can be more budgetary allocations there, more funding for that effort, and that when there are detections of new variants, that information comes to the public as soon as possible, and not just from the scientists with their limited audience they have from their platform, but from the public health authorities who have a mandate and responsibility to communicate those things.
So, Nana, I pick the sense that we may not have enough funds devoted to particularly determine how widespread these variants are in the first place. But you did mention that one of these variants has the characteristic, of spreading at a faster rate than what we are used to. Is that to say that the population has a lot more of these variants?
Well, I would hate to speculate because, usually I'd want to see specific data from the broader kind of pillar sampling we do in genome sequencing. But on one hand, we know that the B1 variant might spread faster, but we also know that we already have a dominant variant here that spreads much quicker than ancestral strains, and quite similarly to what the Morocco and Algeria strain does, which is the UK variant that we know is dominant in terms of new COVID-19 cases in Ghana. So we know that we're not necessarily going to see such a significant increase in the spread, but we know that that strain will probably be competitive with the UK strain for dominance in the country. Mm-hmm. It's hard. It's very difficult without having more samples done in more places to have a sense where that's spreading. But the pattern for those variants that have the characteristic of being able to spread faster is that once they enter a population where transmission or infection control measures are not being adhered to, are not proven to be very effective, that they tend to spread very rapidly. And if we're going with the March entry deadline, then we would expect that, or the March entry estimate, or when it was first detected, then we expect maybe 2 weeks before that, 3 weeks before that, it was also spreading. And if you add all that time, it would stand to reason that there will be a meaningful amount of this variant spreading among the population.
Which is exactly what I was thinking, that this variant, pardon my use of a crude expression, has been walking around us for the past year. It must be in a good number of people. So in this conversation, we've established that the vaccines are still safe, are still effective, at least as far as we know. And the number of people who have it is not so clear. What should you say should be the public health response to this discovery by Yamachi and Wakdip?
Well, it's really about going back to basics, or remembering the basics. At the heart of everything COVID-19 is transmission control, it's infection prevention. All the things that we need to be doing to reduce the risk of transmission will be effective for all the variants or for any variant that comes up. So if we are wearing masks in public transit at the rates at which we are supposed to, it will be effective at reducing the spread. If we are trying to limit our attendance and hosting of social gatherings, large weddings, large funerals, which we know are happening, those things will also be effective at reducing the population level risk. But there's also things that our public health agencies have to still be doing. They still have to be doing testing at a much larger level, at much higher rate. We know that basically since the start of February, we've seen a gradual decline in the average daily testing number, through mid-February, a gradual decline in the average testing number, so that right now our 7-day average is about 50% of the February high. That's about 7 tests per 100,000 people per day. And it's not difficult to see how that testing rate will make it very difficult to get a representative idea of infections in our communities, and how they'll also make it difficult to do effective contact tracing, especially because we are seeing that from the public health labs, there seems to be a testing lag there where samples can sometimes take 2 or 3 weeks to get a report out, the average looks like maybe about a week or so. But if you look at the timing of how this infection transmission chains happen, you only have about 3 days to do effective contact tracing. So if we're not getting results back in that time, it's going to be difficult. So we have to really get back to the effort of making sure that we're expanding testing capacity, bringing to bear antigen testing, as we've been saying we'll do for months now, and also making sure that we are speeding up the rate of contact tracing and the pace of that testing in that respect, so that we can do early isolation, early quarantine, and break the chain. But it goes back down to doing the basic things we're supposed to be doing as individuals and as public health officials around the country. Maintaining, good hand hygiene, good social distancing, mask wearing, and then being intentional about the contact tracing efforts and communicating candidly about what we're finding there.
Now, I'm very curious. You threw out a very scary statistic there that we are testing 7 persons per 100,000 people per day. Are you factoring in the tests that are being done in private facilities, those who need to travel, those who feel sick and will go and pay an amount, maybe those who are taking tests as part of medical procedures? Are all those parts? Because we also know that in cases like that, it's most likely contact tracing does not necessarily happen.
Of course. So we know that a lot of that voluntary testing, when people test positive, they usually contact their own, they report to Ghana Health Service, but what we saw through January and early February was a lot of people who got infected then through private testing contacted their recent people they had come into contact with recently, and those guys then went and got tested kind of on their own in those kind of chains. What I'm talking about is a statistic that includes all that testing. We are made to understand by Ghana Health Service that the data that's on their website that comes from routine surveillance and contact tracing combined represents all the testing we're doing in country, including tests done at private labs. And it's when you take that number and divide it by the population that you get that 7 tests per 100,000 people per day. So we are looking at all those things being included in that figure.
Nana Kofi-Kwakye, thank you very much for joining us this afternoon. He is a public health expert, adjunct professor at New York University.